prostate specific antigen, also known as the human kallikrein peptidase 3, it is secreted by the prostatic epithelium, and it is organ specific but not disease specific due to the significant overlap between the various prostatic disease. Next slide. There are various causes for the prostatic PSA elevation, like carcinoma of the prostate, race, particularly African Americans, benign enlargement of prostate, in which there is a 4% rise in the prostate with per ml of the volume of prostate, acute urinary retention, prostatitis, prostatic biopsy, which normalize usually in 4 weeks, and after ejaculation, that too in more than 50 years of age, which normalize usually after 24 to 48 hours. Next slide. The cause for the elevated PSA level are probably a product of disruption of the cellular architecture within the prostate gland due to the loss of a barrier afforded by the between the basal layer and the basement membrane within the normal gland. It is likely a site for the egress of the PSA into the circulation. Next slide. One of the most common cause of the acute urinary retention is benign enlargement of prostate, and prostatic infarction has been described as a potential cause for acute urinary retention. Spiro et al. Evaluated the role of prostatic infarction as a cause of acute urinary retention by examining the open prostatectomy specimen. In specimen in all, he found 85% of the AUR group patient had histological evidence of infarction compared with 3% of the elective group. And PSA elevation is in acute urinary retention is also secondary to the prostatic infarction. Next slide. There are various studies I have quoted giving the relationship between the interpretation of the PSA in the acute urinary retention. This is one study published in 2002 done by the Zing et al. From China, where they took the more than 50-year-old patient with the acute urinary retention, patient with the urethral stricture, neurogenic bladder, prostate cancer, and with the recent history of instrumentation were excluded. Blood sample for the PSA were taken thrice. First was on at the time of a presentation. Second was taken 2 weeks after the just before the catheter removal, and third was done after 3 weeks of in the patient who have voided successfully after the trial of catheter removal. They concluded that acute urinary retention increased the PSA level by approximately 2-fold, and this effect may be continue up to 2 weeks. Next slide. This is a study done in 2005 in which they studied the efficacy of a PSA in the detection of a carcinoma of prostate in the patient with acute urinary retention, where 54 patients aged between 55 to 89 with acute urinary retention were included. And they found that 5 patients were found to have a prostate cancer. Significant elevation in the PSA was associated with acute urinary retention. Only 15, that is 28% patient having a PSA of a 4 nanogram or less. Thus, this elevation reduces the sensitivity of a PSA in detecting the carcinoma of a prostate even with cutoff of 20 nanogram per ml, and the positive predictive value was only 21%. Next.
Akash, go back to your previous slide.
Yes, madam.
Explain कर लो कैसे sensitivity नहीं है 20 के ऊपर.
Ma'am, ma'am, in this study, they found that usually when they take a, they were unable to differentiate whether that elevation PSA is due to the carcinoma of the prostate or it is because the patient with the benign pathology also have with the acute urinary retention at the time they have an increased PSA. So they could not able to label PSA in detection of a carcinoma of the prostate, madam.
So you're trying to say that if patient presents with acute urinary retention, it is not possible to detect malignancy of the prostate, carcinoma of the prostate, even if it is about 20.
Yes, madam, because yes, madam, because it may be secondary to the BPH in which the pathology was suggesting of a prostatic infarction, which causes the leakage of the prostate from the prostatic epithelium, madam. So that may also cause the high prostate, madam.
5 patients, that is 10% have malignancy, 15% have less than 4.
Yes, madam.
28%. That is almost 38% patients will have to be excluded out of it. No?
Yes, madam. Hello.
Yeah, but normally we don't see very high elevation of PSA after AUR.
Yes, madam.
There increase in PSA after AUR?
Ma'am, in the studies, they said it is 2 to 4 times elevated at the time of acute urinary retention, madam, which reduced by up to 50% after we do it 2 weeks or 3 weeks, madam.
If normal PSA is 4, it is increased to 8 or 12.
Yes, madam.
They are given 20 as a cutoff value is not having a positive predictive value.
Ma'am, in their study, even yes, ma'am, only 21%, even with they say 20 cutoff of 20, madam.
Their study they बोल रहे you can't accept everybody's study as face value. You should also think, na 38
yes,
patients good हो गए, बाकी के patients में only 2 times raised. Then how are they saying कि 20 is? I think
yes,
maybe you'll have to read more carefully the study, and maybe then you will get.
Yes. Okay, ma'am. Next slide.
I'm not saying that they will be wrong, but I think on cursory looking at this slide, you feel something is not right. Okay, next slide.
So, according to their study, PSA should not be performed at the time of presentation with acute urinary retention. For those in whom a PSA is desirable, a delay of 2 weeks should be allowed prior to sampling, as half-life is half-life of PSA is 2 to 3 days. Next slide. There's one more study of effect of acute urinary retention on PSA and prostate antigens phosphatase. It is published in IJU in 2005, done by the Dr. Chavla sir. He conducted this study to study the relevance of PAP estimation with or without PSA in patient with acute urinary retention. Mean PSA and PAP value in adenocarcinoma group were significantly higher than in BEP group. It was observed that the PSA level was raised in the BEP group with the urinary retention as compared to those with no urinary retention. But there was no change in the PAP level in BEP patient. Next slide.
Adhar, in your previous slide also, go back to the previous slide. Acute urinary retention is treated by what?
Ma'am, usually we catheterize. We first, the patient comes in retention, we catheterize the patient, madam.
Statement like this, that in whom PSA is desirable, a delay of 2 weeks should be allowed prior to sampling, because in between there is an event of catheterization, right, and catheter removal also, which also increases the PSA. So I think it can be linked with the TOC.
After 2 weeks of TWOC, madam.
2 weeks of TWOC, but यहाँ तो AUR लिखा है तुमने.
Oh. Ma'am, it is 2 weeks prior to, after ma'am TWOC of 2 weeks after TWOC.
The TWOC will vary from 3 to 7 days after time of presentation of AUR.
Yes, madam. Yes, madam.
Okay, next slide.
Next slide, please. PAP therefore appears to be particularly important. Hello?
Just 1 minute.
Yes.
Yeah, continue.
Yeah. PAP therefore appears to be particularly important in hospitalization with AURS. Catheterization appears to raise the value of PSA but not PAP. Next slide. Therefore, we conclude acute urinary retention increase the PSA level by approximately 2-fold, which may continue up to 2 weeks, and we should do after at least 2 to 3 weeks of a trial without catheter successful. Thank you, ma'am.
Adhar. So
yes, sir.
Other in the PSA, you are telling me the PSA increases and you should ideally repeat the PSA after 2 weeks. Huh?
After if the patient has a successful trial without catheter, then we do after 2 to 3 weeks of TWC successful.
Right, then?
Yes, sir.
If the trial without catheter is not successful.
Sir, yes, after 2 weeks of a successful trial without catheter, sir.
No, sir is asking if trial without catheter is not successful, then when should be done?
Then, sir, if not successful, sir, we'll do after. Still, we'll do, sir, after 2 weeks, sir. We reinsert and.
2 weeks you tell me.
Question is, what happens if the patient is still on catheter?
Okay.
Huh? If the acute episode is over and you still suspect prostate cancer and the patient is still on a catheter, then you will have to do a PSA and then you use these same yarsticks. If the PSA at that time is 20, if the PSA is 20, if the PSA is beyond double this, then it has to be significant. You have to evaluate that.
Okay, sir.
So there is, the thing is that one does not usually do this simply because of patient retention. The problem is there are some patients who will fail trial voiding and you still want to know whether there is. Usually the usual sequence is fail trial voiding, TURP. That's how the whole thing is. Fail trial voiding, TURP, histological surprise. Histology comes back as adenocarcinoma, prostate or what. Then you evaluate the patient on the basis of that. If you have never done a PSA before that, you'll have to wait for some time and do. But since you already have the histology, then evaluate by MRI or whatever else you want to, depending on it. Because patients can still have a radical prostatectomy even if they have gone into retention and you have done a TUR. So both are possible.
Okay, sir.
Hello?
Yes, sir.
Is twofold increase. And usually it never goes beyond 45, 50. Is that the figure you quoted? I just went inside to have a look at a cystoscopy.
No, sir, I didn't.
Okay. No, what is the allowed? You said approximately twofold.
Yes, sir.
But there can be patients who have acute infection also for retention. They can have some prostatitis as a result of that and then retention.
Sir, if the PSA after retention comes around in between 10 to 20. Hello?
Yes, carry on.
Sir, if the PSA is between 10 to 20, clinically the prostate is normal. There is no nodular hardness is not there. So now shall we tell that patient you should wait for 2 weeks or we can go ahead with MRI?
You see, what I remember reading, and we had the same situation in the Vellore masterclass, was the PSA in acute retention never goes up beyond between 40 and 50, never goes up beyond that. So if the value at retention is that high, then it is very suspicious.
Sir,
but even if it did go to 40 or 45, it comes down within 48 hours after catheterization to less than 50% of the original value. So if you are saying that the PSA Bhushan was 20
yes, sir,
before catheterization, and after catheterization in 48 hours, if it remains 20,
okay,
that is significant.
Okay, then we can go ahead with that directly.
Yeah, it has to come down. If the retention was causing this, it has to come down.
And sir, if the PSA is between 10 to 15 during the retention,
yes,
it is 15. After 48 hours, it becomes 10 or 11.
Yes, that's good. That's unlikely. Then you have to wait and see. You treat it and repeat it. Don't rush it then.
So then what is the role of MRI?
Well, when there's a lot of inflammation, it won't help. With a lot of inflammation, then the MRI will be a problem because all your diffusion quotient is all going to be altered, isn't it?
Yes, sir.
So this is a problem with acute retention.